Government Medical College, Bhavnagar.
So today's moderators are myself, Dr. Civil Engineer, Anita Borges, freezing. Please come. Show.
This,
Yes,
it's a
ma'am.
slideshow?
Yes, ma'am.
Yes, ma'am.
Okay. So before we start, just I want to show you guys one approach to diagnosis of thyroid lesions or neoplasms, shared by my colleague Dr. Swapnil. And the way you are going to approach these cases is look for any nodularity if it is single or multiple. Look for if this is a invasive tumor or a follicular nodular disease. If it is single nodular, we have to look for whether it is what kind of pattern it is and whether it is capsulated or not. So papillary patterns, so look for papillary carcinoma, nuclear features. Cystic, it could be benign cyst. So what kind of lining you, what kind of tissue you see in the wall. Then follicular pattern, medullary, we have nesting pattern, high-grade patterns where you look for mitosis, anaplasia, necrosis and all. And then there are some other cases. So when you look at the capsule, if you find capsule, look for capsular invasion and vascular invasion, if any. If you understand this this type of approach to the diagnosis, let's start with the first case, which is a 62-year-old female presented with neck swelling for last 2 years, and on right side neck swelling was there, which used to move with deglutition. USG neck showed right thyroid lobe enlarged with multiple nodules. FNAC was Bethesda category 3, and then right hemithyroidectomy was performed after correlation with radiology and clinical findings. So who wants to take this case? Or should I just arbitrarily call someone?
Ma'am, I will take this case.
My Manasi.
Yes, ma'am.
Okay, go ahead. What do you see here?
Ma'am, this is an section study. This shows thyroid tissue showing nodules, and it is well capsulated. Fibrous capsule can be seen, and multiple follicles of varying sizes can be seen.
What do you see here?
Calcification can be noted, ma'am.
So before we go ahead, I just want to ask you, Mansi, or anyone else, what do you mean by capsule? What when you say capsule, what are you looking at? Thyroid capsule or capsule of the nodule? These are two different things. You can have a nodule within the thyroid which is capsulated. So when you're saying here it is capsulated, are you looking at the thyroid capsule? Do you see any perfectly nodular lesion with complete capsule around it? Anyone
Yes,
wants
ma'am.
to volunteer?
No, ma'am.
You see that?
Architect.
Yes, anyone else? Any of the Apurvas, Bhavesh?
Ma'am, the lesion is diffuse, ma'am, in nature. There is no such capsule within the thyroid itself. It is the capsule of the thyroid gland that we
I
can see
agree
in
with
this
you.
section.
So we do have some fibrous bands which is dividing the thyroid parenchyma into multiple nodules, right? Okay, go ahead, Mansi or Apurva. Any one of you can go ahead with the rest of the. So one thing is clear here: we don't have a capsulated single nodule. We are looking at multiple nodules. Am I right?
Yes,
Okay.
ma'am.
Yes, ma'am.
Go ahead.
Ma'am, follicles of varying sizes can be seen, which are filled with colloid.
Okay.
Ma'am, ma'am, follicular hyperplasia and adenomatous change can be seen.
At higher magnification, what do you want to see and to look for?
Lining
Lining
lining the follicles.
Yes, ma'am.
So these are what type of cells are these?
Ma'am,
Cuboidal
cells. Follicular cells.
Follicular cells are there. Do you want
Yes.
to comment on this follicular cells? When you look at the lining of
Oncocytic
follicles, what do you look for? There are follicular cells. That's it? Or anything else you want to look for?
Ma'am, there is
Follicle cells
oncocytic change in this. The nuclear features of the
Okay, somebody said about oncocytic change. Okay. So that I agree, there is marked oncocytic change. Okay, nuclear
Oncocytic.
features. What nuclear features you are going to look for? Apurva Mathur, you said, right?
So, ma'am, eosinophilic cytoplasm is there, nucleus is prominent.
That is for oncocytic change. When you look for nuclear features, what nuclear features you are going to look for? What are you trying to exclude or trying to diagnose here?
exclude papillary thyroid carcinoma nuclear features.
So
Fecal
papillary carcinoma
Yeah.
nuclear features, what are they?
nuclear clearing,
Ma'am, elongation, overlapping.
override, nuclear overriding.
One person at a
counting.
time. Somebody can take a lead.
Ma'am,
Nuclear
change in
clearing?
size and shape, like nuclear elongation, nuclear overlapping, overcrowding, then membrane irregularities, like pseudo inclusions, nuclear grooving,
Hmm.
and ma'am, chromatin, clear optical chromatin,
That's called as
orphanania.
Orphanania.
okay. Fine. So do you see them here?
No, ma'am.
No, ma'am. No, ma'am.
No, ma'am.
No, ma'am.
So you have seen the WSI, you have seen the PPT. Based on this, what is your diagnosis? You know the history, right? History is enlarged thyroid lobe. And I think the duration is longer. Like, what do you see in history? What is the
Ma'am,
age of the
long-standing.
patient? It is a long-standing one.
Multinodular.
There is no rapid
Multinodular.
increase in size. Okay, multinodular on USG. Now we are not going to discuss details of Bethesda system here, but when it is Bethesda 3, any idea what is the next management? What is the management here? Did we report as repeat definitely or
Molecular testing or lobectomy.
Ancillary techniques.
ancillary techniques may or may not be available everywhere. But if there is repeat testing, it shows same thing. What will you suggest? Or what the surgeon would like to do?
Lobectomy.
It's every time lobectomy. When is lobectomy done? I think Dr. Shiva will give us more insight to this later. But it has to we have to look at the clinical and radiological pictures, and then only lobectomy will be decided whether to do it or not. And in this case, this is a large lobe, but it was removed nodularity. So what is your diagnosis in this case? Tell me.
Multinodular goiter with adenomatous change.
Adenomatous change. Any differences? Anybody wants to disagree with diagnosis or everybody agrees with this? Yes, Bhavesh, Kalyani.
I agree with that.
Okay, who else is there? Kalyani. Kajal.
And I feel it is multinodular goiter with the degenerative changes because calcification, fibrosis, and hemorrhage is there, and oncocytic
Right.
changes.
Exactly.
So it is
I agree with
nodular
you.
colloid goiter with the degenerative or secondary changes.
Excellent. So we have this follicular nodular disease or multinodular goiter with a prominent oncocytic change. So they are calling this as a thyroid follicular nodular disease nowadays. Anybody is aware of recent WHO 2022 classification in thyroid? Anyone of you have gone through it?
Yes, ma'am.
You know it, Kalyani?
Yes, ma'am.
So is this included in recent classification?
Recent classification comes under benign follicular disease.
Right.
It will be
Benign
called
follicular
nodular
derived.
disease.
So benign follicular cell derived neoplasms and thyroid
Under
follicular nodular disease is first time included in the classification which was never included before. Is that
Yes,
clear to you?
Yes,
So
ma'am.
this is one of the commonest cases that we come across in our practice, right? And whenever you come look at these cases, all you have to make sure that you are not missing any focus of carcinoma. And for that, you have to look for all the patterns, capsules, capsule invasion, vascular invasion, and the morphology of the cells. Is that clear to you?
Yes, ma'am.
Do you have any questions in this case?
No.
Okay, should we go with go ahead with the next case?
Yes, ma'am.
I want to comment. Yeah,
Yeah, Dr. Manjula, can you comment on that?
yeah. So the Bethesda has three category. It is a challenging one. So nowadays, recently the artificial intelligence has had some role in the reporting for reporting for the lesion. Though there are some studies are going on, so that have some role. And as you said, it is in 2022. It's a newly introduced because this enigmatic criteria for the diagnosis because it is whether it is a follicular neoplasm, follicular adenoma, or adenoma plus hyperplasia, or the hyperplastic nodule. So it is better to have the term like WHO 2022 follicular nodular lesion. So it was unless and until we can go do the molecular marker, of course, we can say it is an adenoma we can diagnose. But only with histology, it is difficult to give the proper diagnosis, and it is not coded for that reason. Okay.
Thank you, Dr. Manjula.
So now, so now we can go to the thyroid.
If there are no questions, can we go ahead with the next
No,
question?
one of the chat. Oh, sorry. Asabri, what I wanted to ask Dr. Shiva, I hope I can call you Shiva Shiv Kumar. Are you familiar with this term, or most people who deal with thyroid disease, are they familiar with this term, follicular nodular disease, or are we pathologists now just introducing terms where multinodular goiter was a good term before?
Yeah, so This is a new term. Yes, I'm not sure if everybody would be well versed with this WHO 2022 the new classification that has come up with. So we still, I would say that the large majority of surgeons would probably not be familiar with this. That's what I would say as of today. But maybe I think even it will be difficult for them to get familiarized with this term. I think they'll be referring going back to multinodular goiter more than this.
Yeah, that's something that I would like to make a mention of. We are all enamored of new classifications, new terms, etc. But I think that we need to understand something, and that's exactly what Dr. Shiv Kumar said, and that is that we have to use terms that are understood by our clinical colleagues. And so, if we are going to use or introduce something new, a synonym should be used, along with it, so that you educate the surgeons or those who are going to use this or understand this terminology, and not just start using terms which the treating clinicians do not understand. I don't know if you agree with me, Asawari and Swapnil.
Yeah, we do agree with you, ma'am. So every time new classification is there, we always have some new entities. And initially we start giving although we start giving those diagnoses, there has to be some comment. What was it called earlier? How it was addressed earlier?
Yeah, that's one thing. But I'll tell you what the worth of this follicular nodular disease actually is. If anybody was familiar with follicular adenoma in the previous classifications, the definition was that there could be just one follicular. It was a solitary disease, and it was very obvious, and it was obvious to most of us who practice in areas of where there is still goitrous disease, that you had a multinodular goiter, and in a multinodular goiter you could have 3 or 4 or even more completely encapsulated lesions, which otherwise would fit the definition of a follicular adenoma. So now what do? Do you call them multiple follicular adenomas in a multinodular goiter? And I think that this thyroid follicular nodular disease has come about as a way of overcoming this, I thought, ridiculous definition of just one adenoma in the thyroid. And it was devised in the West, where they didn't have much goitrous disease. In the sub-Himalayan areas and in many parts of our country, we have a lot of goitrous disease, and it hasn't disappeared despite the iodination of salt and all that sort of thing. Anyway, Asawari, you can put up your definition of thyroid follicular nodular disease.
It's similar to what we said just now. It can be called multinodular goiter, it can be called multinodular thyroid hyperplasia or adenomatous nodule. And basically, they are including it because it shows multiple clonal and non-clonal nodules. This is the first time they have included in their classification. Sometimes it can show papillary pattern also. Basically, it's very blunt, no nuclear features of thyroid carcinoma, and there is no invasive growth. I think we can go ahead with the next case. Okay, so this is a 27-year-old female presented with a left neck swelling, noticed 3 months ago, gradually increasing in size. On ultrasound, it was 1.6 centimeter TRAS 4, and FNAC was suspicious for follicular neoplasm, Bethesda category 4, and hemichyrectomy was performed. Okay, who wants to take the lead?
Ma'am.
Yeah.
The section examined shows an encapsulated nodule containing follicles of varying sizes, macrofollicular pattern. You can see.
So
most of the macro follicles are filled with colloids.
So we have a capsule here. Once we see the capsule, what are you going to look for?
Invasion.
Invasion. There is capsular invasion or vascular invasion.
Did you find anything?
Not here, ma'am.
No?
So one thing
No.
before you go ahead is that I'd like to point out is to look at the cellularity of the lesion. Okay, so if you compare it to the cellularity of the previous case, there is a dramatic difference in the cellularity of the lesion. Now, the presence of this kind of cellularity and very closely packed small colloidal follicles at times is something that should point towards you that this is not simply a non-neoplastic lesion. It is likely to be a neoplastic lesion. It is not on the lines of multinodular. So you could have multiple nodules like this, but it's not something that you should consider as a multinodular disease or follicular nodular disease. So at low magnification itself, to me, this points towards a neoplastic disease with some sort of a capsule around the lesion, and obviously there is a predominant follicular microfollicular pattern. Okay, then you can actually dip down deeper to look at the capsular invasion and other invasive features that point towards it. Once you have a capsulated single lesion with a follicular pattern with this kind of high cellularity, there's some form of a follicular neoplasm with a capsule. And if you have adequately sampled it, you should be able to comment on whether there is invasive invasion into it or not. And there are a lot of definitions. Like in this focus, you can see that even at this magnification, which is roughly a 10x magnification, you can see there is something that is jutting out from the capsule. And this is one indicator that there is a capsular invasion. There are many definitions of what is capsular invasion and what is incomplete capsular invasion, what is a questionable capsular invasion, and things like that. And based on those definitions, you have to decide between a range of diagnosis, ranging from widely invasive follicular neoplasms to minimally invasive follicular neoplasms to a follicular tumor of uncertain malignant potential. So it's a spectrum of tumors that have a similar morphology. And once you have decided this at, let's say, 10x or even 20x, and then you finally jump down onto the 40x to look at the nuclear features, just to say whether this is it has papillary nuclear features or no. Does it have increased mitosis, any necrosis that there is in this case? Because the presence of either the papillary nuclear features is going to change the diagnosis. The presence of the mitosis, which currently is defined as more than 5 mitosis per 2 mm square. 2 mm square is roughly 10 high power fields. Okay, there's roughly 10 high power fields. So that is the general approach I would take with this kind of lesion. Start at low magnification. The cellularity test is neoplastic. At low magnification, I can locate the capsule and see that it is complete or incomplete. And if I see a complete capsule, I'm now looking for capsular invasion. Again, at low magnification or intermediate magnifications, and then only then, when I jump back to 40x, it's only to look at papillary nuclear features, anaplastic features, and nuclear anaplasia, not the architectural anaplasia, but nuclear anaplasia, and mitotic figures to rule out highly differentiated thyroid carcinomas or some other lesion like that. So, this is my general approach to this kind of a case. Okay. Now, truly speaking, there is no thyroid. The thyroid gland truly does not have any capsule. It is just some condensation of the connective tissue around it, and the capsule that we talk of in this is actually of the thyroid, whatever lesion that we are looking at. Okay. All right, let's go ahead with this. So in this case, this particular location has this capsular invasion. Okay, and then you would search for vascular invasion. So and then you count how many foci of invasion are there. So this is definite capsular invasion, which is going beyond the capsule, almost like a mushrooming kind of a thing with the two capsular threads at both the sides, and then something jutting out of the capsule. And so this is good enough for a capsular invasion. And if there is no vascular invasion, I would no nuclear features of PTC, I would call it invasive, minimally invasive follicular carcinoma. But if on high power I see papillary thyroid carcinoma features, nuclear features of PTC, then I would call it invasive encapsulated follicular variant of PTC. Okay. So as a rule, most of these diagnoses are morphology based and not really any other IHC based or any other features.
So now,
So in this case, there are obviously nuclear features of PTC like clouding and clearing and irregularity, and I think some grooving as well.
so can you describe that? Who is describing? Apurva?
Yes, ma'am.
What do you see here? What have you noticed all these features?
Yes, ma'am. Yes, the clearing is there. Then proving is also there, ma'am. In the next slide.
Yeah. So just enumerate all the positive points what Dr. Swapnil just taught you and what you have noticed in this slide.
And there is nuclear clearing, overcrowding.
And start from the beginning, Apurva. You saw capsulated neoplasm, right?
Yes, ma'am. The encapsulated neoplasm. There is capsular invasion seen.
Okay. What was the pattern? We found there's capsulated neoplasm. The tumor is what kind of pattern tumor is? What kind of patterns do you know in tumor? Thyroid tumors, what type of patterns you have seen?
Follicular pattern. Here.
That's it? In this case, follicular pattern. What other patterns you should? Anyone else? Who else is there?
Ma'am, we can see
Papillary
capillary pattern.
microfollicular pattern.
Oh, yeah. So go ahead. What are the patterns?
Ma'am, follicular, microfollicles, macrofollicles, papillary pattern as nests. Then
Any other pattern? We are going to look. You have seen those cases. We have shared some of the cases which show all other patterns. What other patterns you see?
Trabecular pattern.
Trabecular, and what else? So you see solid pattern. You see
Solid.
the pattern.
all cell pattern.
That is different. All cell is different. That's a different subtype. Patterns, we are talking about the arrangement of cells. So commonest is the follicular one, and we are going to look at those cases with follicular pattern, those thyroid tumors with follicular pattern, how to approach to the diagnosis. Okay. So this is what you're looking at, the follicular pattern tumor. Now you tell me the diagnosis.
Follicular variant of pattern.
What is it?
Invasive capsulated invasive
Follicular.
follicular variant of PTC.
That's fine. So what kind of invasion you will call this? Is it a minimal invasion or widely invasive?
Minimal invasion.
So that's right. Invasive encapsulated follicular variant of papillary thyroid carcinoma, right? So whatever Dr. Swapnil told you just now, let's have some quick recap of this. When you're looking at capsulated tumors, so you want to go ahead?
Yeah, I mean, this is what we discussed, that once you have decided that this is an invasive encapsulated follicular carcinoma or follicular variant of PTC, you need to subclassify it further as either it's minimally invasive or widely invasive and angio-invasive. Okay, and unlike PTC, encapsulated FPPT is actually much closer to follicular neoplasms or follicular carcinomas because they have more of RAS mutations than RAS mutations. Okay, that is how this happens, and most of these tumors don't actually go to the nodes. They behave more like follicular carcinomas despite the nuclear features of PTC.
So you can see follicular pattern in multiple thyroid lesion and benign thyroid also. And as we said, we have to look for nodularity, capsule, nuclear features, and patterns. And follicular pattern can be seen in benign tumors, low risk neoplasms, and malignant neoplasms. What we are going to look for is whether it's capsulated or not. Yeah, go ahead.
So before that, I'd like to, when we talk of patterns, there are two things. One is architectural patterns, and one there is a cell types. So tall cell, columnar cell, hormonal cell, clear cell. These are all cellular features and not architectural patterns. On the other hand, architectural patterns are more like capillary, microfollicular, trabecular, insular, solid, and things like that. So when we talk of patterns, we're talking of architectural patterns and not cell type. Okay. So always make the distinction that architectural patterns you are trying to detect all of that at low magnifications, 4x and 10x. While cell types you might have to go at a more high magnification, maybe 20x or so.
Okay.
So there are some synoptic like reporting points that you can at times use. So these are just some pointers towards what all the things you should be looking at, so that you don't miss any of them. And based on the findings, you can divide into other things. By definition, the papillary architecture should never be more than 1% of the entire tumor that you see in when you want to call it follicular variant of PTC. The very reason is that a tumor which has more than that much amount of PTC papillary features is more likely to be a classical PTC rather than something that is closer to follicular neoplasm. Okay, and the one basic thing is that most of the follicular neoplasms, which include follicular variant of PTC, will have more of vascular invasions and vascular spread rather than lymphatic spread. Unlike classical PTC, which is more of lymphatic spread than vascular spread. Right. So if you see classical PTC, you essentially want to have also the neck node dissection and things like that. But encapsulated follicular variant of PTC or the follicular carcinoma, whether invasive, minimally invasive or not, or widely invasive, they are unlikely to have nodal metastasis. This is the diagram that we classically refer to in multiple books as well as the CAP protocol for deciding what is a definite capsular invasion. So so something that has to go. This is obviously an idealized diagram. Okay. In real life, you will actually find much more complicated situations, but the general principles remain the same.
So whatever you see, C, D, E, H, these are all examples of capsular invasion. Similarly, for vascular invasion, again, you have to look for the vascular invasion in the capsule or outside the capsule like this. Directly the tumor budding out is not just a vascular invasion. You have to see the endothelial cells with tumor attached to the vascular wall. So again, just to have a quick recap, we are looking at capsular and vascular invasion plus papillary thyroid carcinoma like nuclear alteration, right? If both are absent, capsular and vascular invasion are absent, PTC absent, like nuclear feature absent, this is called as follicular adenoma. Is that clear to you, right?
Yes.
Now, when we have capsular or vascular invasion and PTC like nuclear alteration, what is it? Refer to this diagram. Look at this. And some one person can answer. I want to know whether you are you can see this diagram, this table or not.
Yes, ma'am.
Yeah. What? This is invasive capsulated follicular variant of PTC, right?
Yes, ma'am.
So now there are some areas, some cases where you are not sure whether the capsular invasion is definitely present or not, what they call it is questionable. But before we put anything in this category, we have to sample it extensively, take the deeper cuts and make sure that we are not missing a true capsular vascular invasion. Similarly, you may not be sure about PTC-like nuclear features, and there they are putting this cases in well-differentiated tumor of uncertain malignant potential, but certainly nobody likes this diagnosis, definitely not the surgeons. We have to make extra efforts to make sure that whether it is fitting in any one of these categories like NIFT-P. What is NIFT-P?
Non-invasive
So we looked at this invasive encapsulated follicular variant of papillary thyroid carcinoma that shows PTC-like nuclear features, right? But that should have capsular vascular invasion. If it is completely absent, this will be NIFT-P. So it should be clear to every one of you that when you call it NIFT-P, can you call any value diagnose NIFT-P on one or two sections? If you get a case for second opinion, suppose, and we have only two sections available with some capsule, are you going to call it as NIFT-P just because it is not showing any capsular invasion? So definitely we have to make sure that entire tumor capsule is sampled and we don't see any capsular vascular invasion. Then and then only we are going to call it as NIFT-P. Is that clear to you?
Yes.
Now, capsular vascular invasion present, but PTC-like nuclear features absent. That is going to be
Follicular
follicular carcinoma. So just remember this table very well, and it will be easier for you to diagnose these conditions. Basically, adequate sampling is essential for adequate sampling of thyroid capsule, not capsule of the tumor is essential to make a diagnosis of NIFT-P. And just these are some important features of NIFT-P. I think all of you know that. So, any questions on this case, Dr. Manjula? Would you like to say something?
Yes. So the diagnosis of this case that was invasive encapsulated follicular variant of papillary. So if you keep in mind in the synoptic approach of reporting, as Dr. Rani has described, it is very easy to diagnose the cases. And he has mentioned another very important point, that is the mutation, race mutation in this case of tumor, this encapsulated tumor. And in case of the NIFT, so this is the WHO has not mentioned the carcinoma, that is the non-invasive follicular tumor, which papillary like nuclear, but it is named is not given like carcinoma. So the prognosis is very good of this tumor, and the nomenclature is also very nice without giving the nomenclature of the carcinoma. So this is my point in regarding this case.
Thank you, Dr. Manjula. Can I ask one question?
One last point I'd like to make is that by current WHO criteria, we cannot really make a diagnosis of NIFT-P without molecular studies.
Yeah.
So we need a BRAF mutation to be absent in these tumors, without which we cannot really make a diagnosis of NIFT-P. So even if everything is satisfied, we have extensively sampled the lesion, we can only possibly suggest a diagnosis and then ask for a BRAF mutation study. And only after that is proved to be negative, we can conclude that it is NIFT-P. The very purpose of this is that we want to keep this entity as pure as possible because it has excellent prognosis. It has no need for any node dissection, and there is it's practically the lobectomy is the cure for this particular disease. Okay, so this has to be kept in mind that we essentially cannot give a diagnosis of NIFT-P on HNE alone.
Yes, that is a very important point. Yes, we have to go for molecular test also. Yes. Thank you.
Dr. Shiva, you were going to say something. Sorry, you were raising your hand.
Yeah, I just want to make one point regarding the, so what I've seen over the many data sets that we have looked at, of what is the most common, on the thyroid malignant data set that we have, is that after the classic variant, the follicular variant of papillary is the most common that we see, and the follicular thyroid carcinoma is very less. And there was a mention made on multiple occasions that the follicular variant, the chances of distal metastasis is more without lymph nodal metastasis, which is not what we actually see. They very much behave like the papillary. I mean, clinically, whatever cases we have operated and we've seen, I'm not talking about the entire spectrum of it. Maybe it might be the case when you look at the entire spectrum, but at least the cases that we have operated and treated, it seems to be following the pattern of the papillary thyroid carcinoma. That is the one point that I just wanted to mention. And also regarding the Bethesda 3 and 4 nodules, it's always a very tough call as to how to treat them. So clinically, if I have a Bethesda 3 nodule, probably will repeat an FNAC. If in the first FNAC it comes as Bethesda 3, and if it comes as a Bethesda 3, then I think the clinical features, factors, and the radiological factors, especially the ultrasound features of the nodule in question, needs to be considered. We're not going to operate a patient or not operate a patient just because it's Bethesda 3 or 4. Now that is one of the factors. Now along with that, what are the other clinical factors? Whether there's any history of radiation exposure, whether there's any family history, whether it's a male or a female patient, whether the patient is less than 55 or more than 55 years of age, and then the various ultrasound features, the echogenicity, the microcalcification, taller than wider. So there are multiple factors to it. So I would just want to stress upon the fact that yes, you have Bethesda 3 and Bethesda 4. You're not going to operate or not operate just because whatever the Bethesda category is given. Unless and until they say it's a malignancy. Even if it is malignancy, there are various other factors to be considered. So this we need to understand. Also, the risk of malignancy in Bethesda 3 and 4 is what's given in literature may not be the same across institutes. We've seen in our own institute that the risk of malignancy is higher than what is reported in literature. So it may vary across institutes depending on whether it's a tertiary referral center or cancer center that is. So there are various other factors to it. So the risk of malignancy in general is what is given in literature, but it may vary from institute to institute. So you need to look at it, and then we're not going to operate or not operate just based on Bethesda 3 or 4. There are other factors which I just mentioned. We'll also be looked into very closely before we make that decision. These are the points I wanted to make.
Yes.
Thank you very much, Dr. Shiva.
Asawari, can I just address
Yeah.
one of the question sort of statements that Shiva just made? Okay, and that is about follicular variant of papillary thyroid carcinoma behaving like a papillary thyroid carcinoma. I think we have to understand that the case that was just shown by Asawari is quite different from the diffuse follicular variant of papillary thyroid carcinoma. And I think, Shivkumar, if you take the diffuse follicular variant of papillary thyroid carcinoma, which is not this case at all, this is an encapsulated tumor, okay, which has now got invasion of its capsule. That is an extremely rare occurrence. Okay, and I just address that. I know that this is for postgraduates, and therefore postgraduates should not get unduly burdened with all kinds of complicated statements. But the diffuse variant of papillary thyroid carcinoma behaves like a papillary thyroid carcinoma with metastasis to lymph nodes and lymphangitic metastasis to the lungs. The encapsulated variant of what we are calling papillary thyroid carcinoma is actually related to NIFTP because it is a RAS mutated lesion.
Mutated.
And it is a complete misnomer that it is called an invasive, follicular variant of papillary thyroid carcinoma. It's a RAS mutated lesion. Why should we call it a papillary thyroid carcinoma at all?
Yeah, that's true.
It's a ridiculous. It's a perversity that this name has been given to this lesion. Okay, you have a non-invasive follicular tumor with papillary thyroid nuclei, which is NIFTP. Why don't we call this lesion an invasive follicular tumor with papillary thyroid nuclei? But we don't call it that. Now we're calling it invasive follicular variant of papillary thyroid carcinoma. So that lesion, which Asawari has just shown, is a rare occurrence, and it's not going to behave like the standard diffuse variant of follicular variant of papillary thyroid carcinoma. I'm just addressing it, not for the postgraduates, please, but for some other people who may be in the audience, and just to address the question that Shiv Kumar just raised. Okay, so we have to separate these two lesions: the encapsulated one, which is related to NIFTP, which is a RAS mutated lesion, and the ones that are diffuse, which are often BRAF. They may be in children, they may not be BRAF, they may be something else, and it's quite common to see this diffuse follicular variant in kids, where it is very solid and which occurs after radiation therapy. They are not BRAF mutated at all. They are, you have one of the red PTC types of abnormalities in that. But since this is for postgraduate, I'm just going to shut up now.
Thank you,
Thank you.
Thank you,
Actually,
yeah, go ahead, please.
Yeah. No, I'm not sure. Again, I just out of curiosity, I'm just saying that. So what I just mentioned about the follicular variant of papillary that we see in our data set, I'm talking about this diagnosis that we have in the histopathology. Maybe today, if you look at those slides, I'm not sure if you reclassify them differently. But then this is what we have, and maybe it would be a good idea to just look at that. But since 2012 to 2018, looking at the data set, whatever we have operated, it's a large, so 40 to 50% of the papillary thyroid carcinoma was labeled as follicular variant of papillary thyroid carcinoma.
It is not the encapsulated variant, or
Yeah, so
you have to separate them out.
Correct,
And this is beautifully done in many studies. So I think you should look at it before we start saying that there is a difference between our sort of population and the population that they have seen in the West. Okay?
So what you're saying, ma'am, is interesting. That it makes me think that probably we have to go back and look into
Absolutely.
those.
Yes,
Let's see if we want to reclassify them differently. That's what I'm saying.
that's right.
Agree with
The
both of
follicular
you.
variant of PTC is actually a very difficult and confusing terminology over the years. And as I said, there is an invasive follicular variant of PTC, infiltrated follicular, which currently WHO calls as infiltrated follicular variant of PTC. Essentially, it is a PTC with follicular pattern. While the invasive encapsulated follicular variant of PTC is not a PTC; it is more of a follicular.
That's exactly what I was saying, and I think that that's what I have against the WHO. They sometimes are so poor in the kind of diagnosis that they have. Sorry, I think
just to conclude, another interesting point is that only 60% of these patients have nodal metastasis. Let me tell you that. So probably need to look at the FPTCs that we have labeled them as FPTCs. Maybe there's something else.
So when we say FPTC, we mean the invasive infiltrative kind of a variant. When we say invasive encapsulated, that's a different entity. Hey, let's go on to the next case.
Yeah, before we go on to the next case, just for students, let's make it clear for them. When we call it as follicular variant of PTC, make sure you look for capsule. If it is completely capsulated, what we discussed now, which are rare tumors, they are like closer to NIFP, and most of them they will not be. So those will be those invasive or infiltrative. There is echo.
Let everybody mute themselves, please, except for the students. Carry on, Asawari.
Asa, you are muted.
Yeah, because I was trying to unmute myself. Okay. So now I think there's no echo. So let's go to the third case.
Ma'am, there is a question in the chat box related to this.
I'm sorry. What's the case question here?
What is the management of follicular variant of papillary thyroid carcinoma? Whether it is in lines of follicular carcinoma or in lines of papillary carcinoma?
Shiva, do you want to take that question?
So I think I want to take that question.
Okay, go ahead.
So there are, as I said, there are two different entities. One is a follicular variant of PTC, which is essentially an infiltrative tumor, is to be treated like a PTC. But when we talk of encapsulated follicular variant of PTC with or without invasion, it is to be treated like a follicular neoplasm.
So I think it's easier said than done because we don't have these information with an FNAC. Now we have to take this call of how to treat this patient based on the clinical findings, the radiological findings, and the FNA findings that is there. So it's not a simple decision like that. So if a patient comes to me with an FNAC of Bethesda 4, now I would tend to do a hemithyroidectomy for Bethesda 4, and then take a call. Now how I do a hemithyroidectomy, and I would counsel the patient that I do a hemithyroidectomy, use frozen, and try to do a total if there are some intraoperative findings that are suspicious, if there are any nodes that is in the central compartment, and things like that. And if that is the case, I do a total in the same sitting. Or else I do a hemithyroidectomy and I wait for the final histopathology report and then take a call as to whether we need to go back in to do a completion thyroidectomy. That again would then would be based on the ATA, that is the American Thyroid Association risk stratification, which is what we follow, as to whether the patient goes into the low risk, intermediate, or high risk. So there are various other things. So it's not as simple as that. If the FNA I get is Bethesda 4, this is the 5 or 6. Again, it depends on the center that you're in. In TMH, I would be Bethesda, I know for sure it is malignant. But in fact, Bethesda 4 malignancy rates are much higher. So I would go in thinking that I'm going to do probably a total thyroid. So it's not. I go with FPTC diagnosis is the final histopathology. I don't have the diagnosis in an FNA, which is what we base on decision to operate under exit of surgery.
Yes, yeah, I agree to that. And but at this point, we are talking about after the hemithyroidectomy. Kalani, can you please unmute yourself?
Yes.
Right. So this is obviously not a discussion on the FNA part of it. This is beyond the FNA. This is focusing more on the histology and the final thing. And one point that is probably helpful if there is a multifocal disease or a single nodule kind of a thing. Madam, would you offer a diagnosis of multifocal invasive encapsulated FPTC if it is a multinodular disease or multiple nodules of the same thing? Or would you rather offer it as an infiltrative follicular variant of PTC?
You're asking me or Borges madam?
Either madam, either of you, madam.
I think I wouldn't give that, but I would definitely like to hear from Borges madam.
Sorry, I didn't quite get the question. What were you saying, Swapnil?
if there were multiple nodules with similar invasive encapsulated variant of PTC like features, would you offer a diagnosis of invasive encapsulated follicular variant, or would you say infiltrative multifocal follicular variant of PTC, as in it is a PTC and not a encapsulated tumor?
I think this is a very theoretical discussion, Swapnil. I cannot remember seeing a case like this. If it is specific to some case that you have seen, possibly, but no, I think that I would not give this as multiple invasive, FVPTCs. And I think that invasive FVPTC is of an encapsulated kind. I don't like to give that diagnosis anyway. I'm sometimes forced to give that, but I think it is. If you look, carefully enough, you will begin to see papilli in this in this kind of tumor. Theoretically, I have never seen it. Have you seen it, Swapnil?
Sometimes the situation arises, but essentially, as you said, most of the time we find enough papilli.
Exactly.
So
I think that
people get confused with that case.
Yeah, I would look very carefully for papilli. And this 1% rule is another hoax as far as I'm concerned, because first it was 1%, then it went to no papilli. Now it's back to 1%, and I think that this is quite ridiculous. And that's why now they have come to this conclusion that you must do a BRAF mutation. I think it's ridiculous. Who's going to do BRAF? Okay, I think that you just decide that you should have no papilli at all, and that's the rule that I follow. I mean, irrespective of what the WHO says. But I think Shiv Kumar will agree, and everybody will agree, that today risk-adapted therapy is what surgery or whatever is what we should use, because these lesions are innocuous from the point of view of what they're going to do. They don't kill patients unless they're very large, or somebody is a male or above the age of 55 or something of this sort. So why don't we use common sense and risk-adapted treatments rather than get into the convolutions of what this is all about? And that's, I think, what Shiv Kumar was saying, that you use risk-adapted decision making for patients who have got solitary nodules in the thyroid. If you have multiple nodules, the question doesn't arise.
Yeah, just on those lines, nowadays, for nodules which are less than 1 centimeter, which is labeled as a papillary thyroid carcinoma, there are a lot of evidence wherein based on certain when they satisfy certain criteria, they're also kept under observation. They're not operated as well. So the concept is changing. There's a good amount of evidence towards that. So we don't have to operate all thyroid malignancies, especially if it's less than 1 centimeter, no nodes, no distant metastasis, no other features. Like these are incidentally picked up. So just to introduce the students to the fact that there are certain less than 1 centimeter thyroid nodules, if found to be malignant, can be observed in a select group of patients.
Thank you very much, Madam and Dr. Shiva. I think that was a very interesting discussion, but this is a very important topic even for students and or pathologists, as the treatment can change the way we approach to this follicular and encapsulated neoplasms. Any questions? If not, should we go for the third case? Okay, so this is a 45-year-old male. Okay, there are two questions. I think there are two questions that have come up.
I'll answer on the chat, but we can go to the next case.
I think so. We can go with the next case. So it's a 45 years male. There is a history of swelling in neck, not 6 months ago, increasing in size for last 2 months, and that's a right thyroid swelling, which is 3.8 centimeter and that's 5. Bethesda, you have clear diagnosis of papillary thyroid carcinoma, and total thyroidectomy was performed. You must be thinking why I'm giving you this case, but I have some reasons, and just let's go with this case. Who wants to take it now? With that,
Ma'am, I'd like to do.
Bhavesh, you want to do?
Yes,
What do you see here?
Ma'am, it shows branching papilla with
Can you
fibromuscular
see papilla at this magnification, Bhavesh?
No, ma'am.
I'm showing you scanner view. The reason why I'm showing you scanner view, in any thyroid section, when we look at the scanner view, it's just to make sure that what you're looking at, whether it is a nodular region, whether it is a capsulated region, whether you can see any extrathyroidal extension. How many nodules are there, right? So tell me, is it a nodular region? Do you see any tumor here?
Yes, ma'am.
It's not a normal thyroid, right?
No, ma'am.
Okay. Do you see a complete capsule to it?
No, ma'am. There is invasion subpartment.
Okay, fine. So let's go ahead now. We'll look at the. I think that's a problem. Okay. What do you see here? You can describe it.
Ma'am, in this slide or the whole one?
Here also, and now you can start describing the tumor.
Ma'am, it shows branching papilla with fibrovascular core. In some areas, the papilla are almost cord-like, and the papilla are lined by tall columnar cells, tumor cells, which have optically clear nuclei and abundant eosinophilic cytoplasm.
Yes. Do you want to call all of these tall cells?
No, ma'am, but majority of them, I'd like to say they are tall cells.
What is the definition of tall cell? And
the length of the cells are more than 3 times the breadth of the cell.
Okay. So do you see that in everything? In the entire section? Yeah, I do agree with you. There are some areas showing tall cell, but there are some other areas as well. What are these areas? What type of cell this is? Anyone else?
Oncocytic cells.
Oncocytic, right? So, in other words, like if you see tall cells, you should not see any other type of cells, or if you see oncocytic cells, you should not see any other type of cells. You can see mixture of all these patterns. Am I right?
Yes.
Okay. So now you have seen this. This is a papillary pattern, oncocytic and tall cell features, right?
Yes.
You agree with me? Okay, what is this?
Yes, ma'am.
What is this? This is what I'm showing here.
Ma'am, this is extension of the tumor.
Right.
Muscle.
It's muscle on both sides. So that is also important, because we have to report if extrathyroidal extension present or absent. If present, whether it is going into muscle or adjacent organs, because that is important for the surgeons. So tell me now, what is your diagnosis?
Papillary thyroid carcinoma, tall cell variant and oncocytic variant with extension into muscle.
So we said because majority of the tumor was showing oncocytic, now they call it a subtype, not variant. Again, changes in nomenclature, but this was majority of the tumor was showing oncocytic type, and then there were focal tall cell features. So now this is clear-cut papillary thyroid carcinoma. Tell me, what are the subtypes or variants of papillary thyroid carcinoma? Who can answer it?
We have a classical variant.
Okay.
Follicular.
Follicular, we had an extensive discussion right now. Follicular, which is infiltrative or invasive. Am I right? This is not encapsulated. Encapsulated follicular variant is completely different. That is taken out. Okay.
Yes, ma'am.
When we say papillary thyroid carcinoma follicular variant, this is infiltrative or invasive. Okay. What are other variants?
Ma'am, Kibriform.
Cribriform is out now. That's a separate entity. What else? Who has not answered so far?
Diffuse sclerosis.
Tall cell variant, columnar variant, hobnail variant, solid variant,
Hobnail
Venus
variant.
cell variant,
Hobnail PTC.
I'm sorry.
oncocytic variant.
Okay.
What is like
Oncocytic. So why we have to specify these variants? Can anybody tell me?
Because the prognosis differs for each.
How does it affect the prognosis? Tell me. Which one of these are good, bad? Any idea?
Tall cell variant has the worst bad prognosis.
What about columnar cell?
Columnar cell has the worst prognosis. Along with that, diffuse sclerosis variant, solid pattern, they have a poor prognosis. And also, whenever there is.
So there are some certain aggressive variants. They are called as aggressive variants of papillary thyroid carcinoma, which include tall cell, columnar cell, hobnail type, diffuse sclerosing type, and all. But one thing you have to remember, when we look at the papillary thyroid carcinoma, just don't stop at whether they are showing a columnar pattern, tall cell pattern, or some other follicular variant. The other thing we have to look at is number of mitosis. You have to count number of mitosis, and second is necrosis. Presence of necrosis in any of these variants always denotes a poor prognosis. Is that clear to you? And now they have been separated out as a separate entity. We are going to see those cases later. Anything else you want to add, Swapnil?
Yeah. So, I mean, in PTC, there is one differentiated PTC, which is essentially a curable disease. Even if the disease is metastatic, there is no meds or even possibly distant meds. Because of radioiodine, most of these patients are practically curable. Okay. The problem is with these other tumors, the aggressive variant, the tall cell variant, the hobnail variant, and then the spindle cell and the other variants. And in addition to what is now called as the high-grade thyroid carcinoma, these tumors do not behave like differentiated PTC. So it is very important as to what you are calling differentiated PTC versus any of the other variants. In general, the definition for calling something a variant is 30% of that pattern, but there is one odd diagnosis where the cutoff is 50%. Okay, so classical PTC can have varied patterns, but as long as the individual cell patterns, the tall cell, the columnar cell, or whatever patterns do not cross 30% of the total tumor that we have examined, the diagnosis can be classic PTC. Although if I see too many of these aggressive patterns, I tend to not call it classic PTC. I tend to just say that this is a PTC and that there are too many aggressive patterns simultaneously present in the tumor, even if individually those patterns do not cross 30%. So this is my take on it, that it is important to identify aggressive patterns and be very selective about the differentiated PTC where none of these patterns are present in a predominant way.
So I also agree with Swapnil. We don't have to try to put it in one category always. It is often that we see there are multiple features, like you can have mixture of all these tall cell features, sometimes hobnail, sometimes columnar together. So, and when you see that, most important what we have to look at it is, look for is sample it extensively, look for any necrosis, and look for any mitosis which is going beyond 5 or more per 2 millimeter square, according to your, you have to find out the size of your field, and accordingly you have to do that. So roughly 8 to 10 fields. If you are getting it more than 5 mitosis or necrosis, then it is altogether a different entity with a poor prognosis. So make sure that you don't miss these aggressive features in any papillary thyroid carcinoma cases. They are not very common, but they are not so uncommon also. Okay. Any other questions?
Ma'am, there is a question. Will microscopic extrathyroidal extension change the stage?
No, I think Dr. Shiva will agree with that. It should be the macroscopic. Am I right, Shiva?
Yeah, you're right. It doesn't change the stage, but then the AJCC staging, if the patient is less than 55, it's only stage 1 or 2, and stage 2 means that there is distant metastasis. And if it is more than 55 is when you have stage 1 to 4. But then we don't follow that as far as the that is just for prognostication, if at all. Now, if you have to decide what additional treatment you would give the patient after surgery in the presence of even microscopic extrathyroidal extensions, now again we'll use the risk stratification that I just spoke about earlier, whether the patient will be low intubated or high risk. So with this microscopic ETE, the patient would be in the intermediate risk group.
Okay.
And in such patients, we would add radioactive iodine as part of the treatment. After surgery, it will be an adjuvant radioactive iodine ablation for these patients. So that is the difference it makes actually.
Thank you,
So
Shiva.
we need to understand one thing. If you can just complete the AJCC risk stratification tells us about the prognosis, the survival, whereas the AT risk stratification tells us about the risk of recurrence. So we are trying to add radioactive iodine to minimize the recurrence. That's the point here.
Thank you very much. Any other questions? Any comments?
Yes, there's one more question. Which is more taller, tall cell or columnar cell?
So the thing is that if you really go by definition, tall cell is like 3 times or more, but I have seen many even well-known pathologists using a little bit shorter cells than that, and they have called it tall cell. So it is not the taller or which one is taller. It is the typical morphology. If you look at it, columnar cells, you have some vacuolated cytoplasm or clear cytoplasm. So all my morphological features has to be noted. Any other questions?
No, ma'am, that's it.
Any comments, ma'am? Dr. Manjula? Okay. If not, should we go ahead with the next case? This is case 4 now. 66-year-old female, swelling on the right side of the scalp and neck swelling. Now left neck swelling moves with the deglutition, where there is right parietal scalp swelling. The ultrasound shows a 4.5 centimeter TRAS4 tumor in the thyroid, and CCT shows expansive lytic lesion in the skull. FNSC shows FNSC was called Bethesda 4, and parietal lesion biopsy was called metastatic carcinoma of thyroid follicular origin. Total thyroidectomy was performed, and this is what it is. So now, who wants to volunteer for this case? Who else has not?
Ma'am, can I try, ma'am?
Yes, ma'am.
Yes, go ahead.
Ma'am, at this power we can see it's a capsulated lesion with high cellularity. At this power we can make out only this much. Going to the higher power.
Do you want to say something about this?
Capsule, ma'am. We can see the capsule, and at this power also we can see the capsule is invaded, ma'am.
Excellent. Okay, let's take your time for me to. Okay, what do you see here?
And this is the capsular invasion we can see here.
So you can see the normal thyroid tissue
Normal
here, you
thyroid
can see the
tissue also.
capsule here, and there are multiple foci of capsule invasion, right?
Yes, ma'am.
Okay, what do you see here?
Ma'am, these are the microfollicles, ma'am. The cells are arranged as microfollicles.
Okay.
Um,
So you look at the capsule, there is capsule invasion, there is microfollicular pattern. What else you are going to look for now?
so the nuclear features, ma'am, there are no papillary nuclear features, ma'am.
They're not very good though, but maybe somebody may call it, may not call it. I think higher magnification, do I have that? It's just clearing, but not very good. Okay, papillary features. I agree with you. Okay. But then there is definitely there is a follicular pattern. Do you agree with that, right?
Yes, ma'am. Yes, ma'am.
What else? Now, when you see this, what else are you going to look for?
Ma'am, I have to look for angio invasion cap. Also.
That we'll see. That will if it is there, I'll show you. What about this? I'm pointing out something.
Colloid, the amount of colloid that is present within the follicles.
It's not the colloid. We discussed something. Okay, this is better seen here.
Vessels.
Mitosis.
So, as we were discussing earlier, we have to look for mitosis and necrosis. Am I right?
Yes,
Yes, ma'am.
Do you see in one field how many mitoses are there?
Here three
Three are there.
So what are you going to call this then? And what is this? The central portion?
Necrosis.
Necrosis. What do you see here?
This is capsular
invasion.
Capsular and probably one vascular invasion as well.
Vascular invasion.
Vascular invasion is there.
Okay. So now what is your diagnosis? Just summarize. So just summarize all the points and tell me the diagnosis.
Ma'am, capsulated lesion with cells arranged in microfollicles with necrosis, capsular invasion, then angio invasion.
So it's not very well captured. This is like the thyroid. Probably it is entirely replacing the thyroid. But yes, we do see a lot of very foci of invasion. Okay, and there is angio invasion. But what is most important here is
Mitotic figures.
mitotic figures and necrosis and pattern.
Pattern.
Follicular pattern. So now how do you want to classify that?
Ma'am, follicular carcinoma with metastasis.
See, metastasis definitely is there, but do you still want to just stick to follicular carcinoma? We said it is when it is necrosis is there and high
Differentiated
mitosis.
high grade.
So what is that called as?
Differentiated high grade.
High grade differentiated. See,
Widely invasive.
so widely invasive follicular carcinoma, that's what earlier it was called, and we used to say there is necrosis and mitosis high. But now these are separated out from other follicular carcinomas because those showing necrosis and mitosis, high number of mitosis more than 5 or equal to 5, they are known to be associated with poorer prognosis. Okay, so now this is called as high grade differentiated thyroid carcinoma, and this is actually there is this entity has been included in a new WHO 2022 classification. Do you know about poorly differentiated thyroid carcinoma?
Yes, ma'am.
How is that?
What do you
Mitosis.
see? Yeah, go ahead.
Mitosis count will be
More than equal to 3 per 10 high
per
power.
unit.
What
And
else?
the necrosis will be there and convoluted nuclei will be seen and we'll be having solid or low.
Solid trabecular insular pattern. But there was one important thing is solid trabecular insular pattern, and there should not be any papillary nuclear features, right?
Yes,
But now here what we see here is in this case we have follicular pattern. It's not solid trabecular or insular pattern, but we have mitosis and necrosis. Are we going to say that it is not poorly differentiated? Definitely it is associated with higher poorer prognosis, right? So now this one entity, high grade follicular cell derived non-anaplastic thyroid carcinoma, you have to understand this concept behind this. If you take this follicular derived malignant tumors, all those papillary carcinomas and follicular carcinomas, when you compare with them, the prognosis of these tumors is worse. But when you compare with anaplastic carcinoma, it is still better. So if you really stratify according to risk, all papillary carcinomas and follicular carcinomas of thyroid, they are somewhat better behaving tumors. High grade follicular derived non-anaplastic carcinomas are intermediate. They do have intermediate type of prognosis, and anaplastic carcinoma will have worse prognosis. Now, in this category, the high grade follicular cell derived, we have two categories. What was earlier called as poorly differentiated thyroid carcinoma, and today's case differentiated high grade thyroid carcinoma. Is that clear to you?
Yes.
And why we are called this? Why we are including them? Because by earlier definition, PDTC or poorly differentiated thyroid carcinoma, as you correctly said, it should satisfy all these criteria, right? But sometimes we do get some papillary tumors, follicular tumors, where we have necrosis, where we have high number of mitosis, and they have equally worse prognosis. So they are called as differentiated high grade thyroid carcinoma. So now our job doesn't stop at diagnosing just follicular carcinoma or for papillary carcinoma with its subtypes. We have to always take efforts to look for mitosis and necrosis. Is that clear to you?
Yes, ma'am. Yes, ma'am.
Any questions on this? Swapnil, you want to say anything? So this is just criteria I have been enumerated in this poorly differentiated thyroid carcinoma. It should not have anaplastic morphology, should not have papillary nuclear features, and as we said, solid trabecular insular pattern with mitosis, necrosis. This is one of our cases just for your just to show you that it has mitosis, necrosis, and a solid pattern. And then differentiated high grade, which will have 5 or more mitosis per 2 mm square necrosis, but it can show papillary features, nuclear features, it can show follicular morphology. And this is another case where you can see follicular features are there, follicular architecture, necrosis, and mitosis. Another case where you see call cell morphology and mitosis. Sorry,
yes, everything included. Yeah, everything you said, madam. But essential thing is that one has to start with the thought that one is trying to find if there are any aggressive features. The aggressive features can be in the form of mitosis, necrosis. They can be in the form of architectural patterns, the trabecular, the insular, and solid patterns, and all the cell types, the small cell, this cell, that cell. And if these aggressive patterns are not there, then you talk of all the differentiated tumors, whether you want to talk of differentiated PTC, whether you want to talk of encapsulated variants of whatever tumor, or follicular carcinoma differentiated, and things like that. So the entire approach has to start from trying to identify these high grade tumors very accurately and not miss them. Because no matter what the patterns and what the cell type, if you find any of these high grade features, they have to be pushed into a high grade thyroid carcinoma or PDTC or anaplastic thyroid carcinoma in that area. Most of the anaplastic thyroid carcinomas will not respond to area as a general rule, and that is also what was expected from PDTC. But I'm sure that there are at least a proportion of cases of so-called PDTC which respond to area. And we obviously high grade thyroid carcinoma is of a new entity, therefore we don't really know what exactly is the response profile to area. So as a pathologist, it is important to identify high grade tumors from these so-called differentiated tumors, and that has to be a basic approach.
Thanks, Swapnil. Any comments, Dr. Manjula, Dr. Shiva?
Can I say something?
Yeah, ma'am.
Asami? the PTTC, which the Turin criteria had, they had specifically ruled out papillary thyroid like features. Okay,
Yeah.
but this was again something that was very perverse, because whenever anybody talked about thyroid carcinomas, you had differentiated papillary and follicular on the one hand. On the other hand, you had anaplastic, and they said that either follicular or papillary tumors would go through a pathway which is increasing p53 and other aggressive molecular features and ultimately become anaplastic. So if the follicular carcinoma was going to go through the poorly differentiated group and become anaplastic, where was the papillary carcinoma going to go? It still had to go through the same. So why did they exclude papillary thyroid carcinoma? And now they have realized that this happens with papillary thyroid carcinoma, and they have just added this group to this PDTC, so-called with the Turin criteria. They just added this high-grade differentiated thyroid carcinoma, which is nothing but a papillary carcinoma, which is showing poorly differentiated morphology. So I think that once again we I don't know, pathologists are strange creatures. I suppose all people have their own idiosyncrasies, but this was an afterthought when people started pointing out, look at all the literature, and people were saying, why has the papillary thyroid carcinoma been removed from the PTTC group? Because it is bound to go through that pathway to reach an anaplastic thyroid carcinoma. Nobody is saying that only follicular tumors become anaplastic. Of course, papillary thyroid carcinomas become anaplastic. So what is that middle point? It has to be a polydifferentiated thyroid carcinoma. So all that they did was add high grade because they didn't want to change the criteria for PTTC. In fact, all of them are exactly the same. So that's exactly what Swapnil was saying. Just identify high-grade characteristics in any tumor that is not obviously anaplastic, and then put it into this group of poorly differentiated, or whatever you want to call it, high-grade tumors, or follicular-derived tumors. It's something that we have to understand was missing in the previous. I don't know, for some reason it was not even considered at that time. I thought it was a huge joke, but it has now. They have realized what they have done. When I say they, the WHO, and it's been added now as a high-grade differentiated. It's not any different from PDTs, but they've just made two entities. I don't know what you or Swapnil think about it. Anyway,
we agree with you, ma'am, and actually that's why our job doesn't stop just identifying papillary thyroid carcinoma or its subtype. We have variant. We have to look for the aggressive features, which are mainly mitosis and necrosis.
Yes, that's all that you need to look at. Solid growth, mitosis, necrosis. And solid growth alone is not enough.
Yeah. Thank you very much, ma'am. Any other comments, questions? If not, we can go for next case. Case number 5. 70-year-old female, large neck swelling, increasing in size in last 2 months. Radiology FNC details were not available to us. It was operated outside, and we just received left hemithyroidectomy was performed. We received the paraffin blocks. Now, looking at this history, anybody wants to say? Who wants to answer the question now? Who has not talked till now? Nikki?
Ma'am, can I try, ma'am?
You want to try, Apurva? Okay, go ahead.
Yes, ma'am. Yes, ma'am.
What does it say? What does it indicate when we say increasing in size last 2 months?
Rapid increase in size mostly goes towards a malignant neoplasm. Indicates a high grade, probably higher grade neoplasm, which can produce more severe clinical symptoms. So, in this section, ma'am, we cannot see a capsulated lesion. It is an ill-defined lesion, and at lower magnification, we can see the borders are also infiltrated. It is not well defined, and on higher magnification, we can see that predominantly it is composed of sheets of tumor cells. And
then you see the 2 types of areas. I'm pointing out to one area. Can you describe this, Apurva?
This shows a follicular arrangement, ma'am.
Follicular and solid, right?
Follicular and solid. Minimum amount of colloid is also present within the lumen of these follicles. And the solid area shows cells that have abundant eosinophilic cytoplasm, ma'am. And these area looks more of epithelial region squamoid appearance with abundant cytoplasm and a centrally placed nucleus. Similar looking area, ma'am.
Okay. Okay, now.
Here we can see necrotic foci, ma'am, and surrounding inflammatory cells we could see. This foci we can see sheets of spindle cells, ma'am. And on higher magnification we can see that there is marked pleomorphism that we can see in the nucleus of the spindle cells. This foci shows that there is sarcomatoid differentiation in this lesion, ma'am. And more higher power we can see that the nucleus shows high degree of pleomorphism. Vesicular nucleus we can see, and prominent nucleoli and bizarre looking nucleus. And they also have abundant eosinophilic cytoplasm and spindling is seen, ma'am. And this first mitotic figures are seen, ma'am, in this.
Okay. So now, what is your diagnosis?
Ma'am, I gave diagnosis of anaplastic thyroid carcinoma, having mixed morphology of having sarcomatoid differentiation along with squamoid differentiation.
And we've had some differentiated areas as well. It's not uncommon completely. You do get differentiated areas sometimes in anaplastic carcinomas, or even if we are looking at a differentiated carcinoma, if you sample enough, you may see changes going into poorly differentiated carcinoma and some areas of anaplastic carcinoma. So our diagnosis is anaplastic thyroid carcinoma with focal differentiated areas. So tell me about anaplastic carcinoma. Who wants to say? What do you see in anaplastic carcinoma? What are the morphologies you can get?
We can get purely sarcomatoid, or we can get giant cells, in which the giant cells will have cells that have pleomorphism. Along with that, we can also get epithelial differentiation. Sometimes we can get paucicellular variant also, or angiomatoid type is there. Rhabdoid differentiation can also be there, and small cell variant and lymphoepithelial-like variants. These are the different morphologies.
Very good. Actually, this is the worst behaving tumor and very bad prognosis. This was the case of anaplastic carcinoma. So, can you have any comments on this?
Like anaplastic, like Dr. Shiva mentioned, even if the histology drives the staging and the prognosis. So if you have anaplastic thyroid carcinoma, no matter how big the tumor is, the AJCC TNM stage actually classifies it as stage 4. Okay, no matter what the size or how it has gone into the adjoining tissues or whether it's metastatic or not metastatic. AJCC TNM classifies anaplastic into stage 4, independent of everything else. The differentiated thyroid tumors have other criteria, age criteria, and other things, and most of them are still stage 1 and stage 2. So it is very important here to identify them.
Thanks, Swapnil. Dr. Shiva, Dr. Manjula, Dr. Madam, I would like to have if you have any comments, madam.
this is one cancer that everybody can agree on, no?
Yeah.
It's just that, when you see squamous cell carcinoma, you have to call it anaplastic. You get various sorts of morphology, adenosquamous, spindle cell, whatever. And that's anaplastic thyroid carcinoma. No, I think the only point to be made over here is sometimes you get a spindle cell, high-grade malignant spindle cell tumor that is involving the thyroid, but you don't know where the epicenter is. And somebody just sends you a biopsy. If this thing is involving the thyroid, you can bet your bottom dollar that it is an anaplastic thyroid carcinoma and not a sarcoma in the neck that is infiltrating the thyroid. This is something that you just learn, that if the thyroid is embedded in a sarcomatoid tumor, that is an anaplastic carcinoma of the thyroid. That's all that is my I'd like to say about
Yeah,
this.
same thing. Sometimes we get in biopsy, we may get squamous morphology. We have to make sure whether the epicenter is in thyroid or whether it is coming from adjacent organs.
Yeah,
That would be also
usually. Yeah, so somebody should do a scopy to see whether the larynx or the
Larynx,
pyriform fossa. Yes.
yeah,
Is the size
that
of this.
can happen
Yes, it
sometimes.
does. But it doesn't involve the entire thyroid. It's usually
Thyroid as it is,
or
yeah.
whatever. Yes.
I agree with you. Any other comments?
Now, two questions are there.
Yeah.
Anaplastic carcinoma, can it arise de novo rather than going through the spectrum? That is one
See,
question.
the thing is that when we say de novo, we may not be able to find differentiated areas. So, yeah, we do see de novo cases and we can get something with the spectrum. But if you sample enough, many times you do find some differentiated areas, which is not always possible in limited material. So, both possibilities are there. Any question?
One of the, I suppose the argument is a differential. Can it be a variant of medullary thyroid carcinoma?
So when it becomes anaplastic, it loses most of all the differentiating markers. It may be sometimes positive for Paxet or TTF1 or pancytokeratins, but it may lose all markers. So we assume it is from it is the follicular cell derived because of the mutations that we see. The mutations usually all the driver mutations and added mutations all are there in anaplastic carcinoma. Plus there are a lot of other molecular changes are seen. And medullary thyroid carcinoma is completely different type. So the clinical profile and the immunoprofile and morphology is different for medullary thyroid carcinoma. Medullary thyroid carcinoma always can have high-grade morphological features, which we'll see later. Any other questions?
Any specific gross features of anaplastic to suspect during grossing?
Honestly, how many times we get thyroidectomy for anaplastic carcinoma?
We don't.
Majority of the patients are not operable. Sometimes we do get what we have seen in grossly it will be like variegated appearance, not typical papillary excrescences and not really capsulated tumor. There will be extra thyroid extension, but we don't get that many. Hardly get any thyroidectomies. If Shiva is around, he can comment. You do how many times you do thyroidectomy for anaplastic carcinomas?
So the anaplastic thyroid carcinomas that present to us, which would be in an operable stage, is very few. Most of them will be locally aggressive, infiltrating all the vital structures in and around. They may present you with distant metastasis already most commonly to the lung. So there are very the number of anaplastic thyroid carcinomas that will be operable are very few as such. Most of the time, what happens is we go in with some FNAC, which is suggestive of malignancy, suspect malignancy, or of that sort, and then you get a surprise diagnosis of anaplastic thyroid carcinoma. So that is the most common type of anaplastic thyroid carcinoma that I have operated on. Most of us also would agree on that even if you ask other surgeons. So knowing that to be an anaplastic carcinoma or thyroid carcinoma, you would go in to operate very few times because it's already locally very aggressive.
Thank you, Shiva. That happens many times. We call something like Bethesda 6 on FNAC, but we don't see anaplastic features. And then these cases, if they're operable, they're operated. And as we sample enough, we do see differentiated areas and some anaplastic areas. We tend to end up calling it anaplastic carcinoma. That can happen sometimes. Are there any other comments? Any questions, students?
No other questions.
No questions. So we go for the next case.
Yes, I do.
This is, I think, last case, and then we have one spot case. 37-year-old female presented with anterior neck swelling, both thyroid lobe enlarged, quite big one, 5.8 and 5.2. On CT scan, there were multiple thyroid nodules, and on FNAC, we called it as Bethesda category 5 or not 6. And the total thyroidectomy with frozen section and bilateral native section was performed. So who wants to take this case? Who has not answered so far? Let me see. Who is that?
Huh?
I can't see. Just tell me your name.
Kalyani.
Kalyani, go ahead. What do you see here?
And then we can't see the capsule, this infiltrating neoplasm.
Correct.
On higher power, the tumor cells are predominantly arranged in nests and insular pattern. They're also in some solid pattern. And there is necrosis.
Okay, fine. Yeah, go ahead.
So, and the tumor cells are shows central necrosis, like comedo necrosis can be seen.
Yeah.
And they are predominantly nests, and they are small cells with scan to moderate cytoplasm with nuclear pleomorphism. And mitotic figures are there. Mitotic figures can be seen.
Okay.
And this is like spindle cell.
Yeah.
And this is vascular invasion can be seen in one area.
I haven't pointed out that, but yeah.
Next down.
Okay. What do you see here? These are all okay. Now is your vascular invasion, right?
Yes. This is the vascular invasion.
What do you see here? What is this? We have seen in earlier case as well. Is this skeletal muscle?
A skeletal muscle involved, and it is infiltrating into the nearby skeletal muscle.
So extrathyroidal extension is present.
Yes, ma'am.
What about this? Can you identify this organ? What is it?
Parathyroid. It is also extending into the parathyroid.
It's going into parathyroid. Right.
Yes.
So now what is your diagnosis? What do you want to do here? You said there is necrosis, there is nesting pattern or solid pattern, or there is increase in mitosis.
Yes.
What do you want to do further?
And it can be either a poorly differentiated thyroid carcinoma.
That's one thing. Okay, that I agree with you. And
or it can be any metastasis, like from
metastasis. What else it can be? We have spindling, we have nesting. Anyone can say. Anyone can tell me.
medullary only.
Is the medullary thyroid carcinoma should be in your differential diagnosis.
Yes.
Especially when you see this nesting pattern and some spindling area. Sometimes the nuclear features are not very well seen.
Yes.
But if you see stipple chromatin, am I right?
Yes,
So
ma'am. Stipple
it's
games.
always you're not going to get that amyloid deposits. Not every time you're going to see that. So now tell me, in this case, what ISIS or immunohistochemistry markers you're going to do?
Then like we do synaptophysin and chromogranin, it will be positive in medullary carcinoma thyroid.
What is specific for medullary thyroid carcinoma? Specific marker for medullary thyroid carcinoma. Who wants to tell me?
Calcitonic.
Calcitonic. Okay. Now what is this PAX marker? That's for thyroid. You can see the thyroid follicles, right?
Thyroid follicle
Tumor is
lineage
negative. What about TTF1? If I do TTF1, then whether this cells will be positive for TTF1 or not? Anybody knows? No? They will be positive. There will be focal positivity. It may not be as strong as thyroid follicle cells, but you may see. But PAX can be negative. This is chromogranin. Positive. In the tumor cell, you have negative follicles nearby. Same is true for synaptophysin and calcitonin, right? So now tell me, what is your diagnosis?
Medullary carcinoma.
Medullary thyroid carcinoma. Now again, for medullary thyroid carcinoma, do you think you should stop at that level only? You call it medullary thyroid carcinoma. The patient already has multiple nodal metastasis, right? Now, what else you want to look for in medullary thyroid carcinoma? Do you have any idea about high-grade features in medullary thyroid carcinoma? Yeah, I think Dr. Sangeeta is saying MEN. Yeah, 75% of cases are associated with germline mutations, so you do look for syndromic syndrome-associated features. But when you have this again we have the echo. Turn off the second device. Okay, so now you have made a diagnosis of medullary thyroid carcinoma. What else you want to look for? You have already seen that. High-grade features. These are the high-grade features which you have to look for and which are present in our case, right? Tumor necrosis, mitotic count may be high or not, and if you want, you can do Ki-67 in these cases if we don't see rest of the features. So if you see, when you get a case of medullary thyroid carcinoma, look for high-grade features. Look for any tumor necrosis is there. If you look for any increase in mitosis, and look for any Ki proliferation index more than 5%. If these features are absent, you are not going to call it as low grade. We have to just say that high-grade features are not seen. Is that clear to you?
Yes, ma'am.
Okay. So now for amyloid, what will you do? Which then you do?
Convoluted state.
Okay. Now any comments? Swapnil?
So whenever you see medullary thyroid carcinoma, you also have to look at the adjoining thyroid for T-cell hyperplasia. This is something that you should do by default. Do you know what is the significance of that? Most of the medullary thyroid carcinomas are going to be what you call sporadic. But if there is coexisting other lesions like a parathyroidadenoma or a T-cell hyperplasia simultaneously in the adjoining thyroid, this particular patient is a candidate for a syndromic workup and genetic workup. So you have to look at the adjoining thyroid and any parathyroid disease. And if you find something happening there, then even parathyroid hyperplasia, or in this case, the parathyroid was not very benign looking. Okay, it is not a normal looking parathyroid even in this case. So over here, this particular patient is a candidate for MEN syndrome or other genetic syndrome workup. Okay, so your histology will also guide clinical management beyond just the immediate tumors. So this is something important for the patient, for the family of the patient, and so you should keep your eyes open for markers that point towards syndromic or genetic conditions. Okay, so the medullary thyroid carcinoma is one such a very strong example. So I had one question which is probably not related to this, and this is directed both at Dr. Shiva and Dr. Borges as well. That in differentiated thyroid, we obviously talk of gross CT as for staging, etc. But microscopically, sometimes we see tumor going into in the muscle outside the thyroid, which essentially is nothing but the strap muscle. Okay. Now, something that is seen on microscopy going into muscle, but is not mentioned grossly, or what exactly is the definition of gross CT? To my mind, something that on microscopy is going into strap muscle is essentially missed on gross examination, or it would qualify for gross CT. But what is the definition of gross CT under that? This is a very confusing area at times.
Shiva going to take that? Shiva's disappeared?
No, I'm here. So, sorry, I didn't hear the question again. So, if you can just repeat the question.
Yeah, so we know that gross CT actually qualifies for upstaging, okay,
Yeah,
stage 4 or whatever. Yeah. But the definition of gross CT is not very clear. Like in this case, there is tumor going into the adjoining muscle, which essentially is a strap muscle. Okay,
that's right.
Now, theoretically, we should have seen this grossly as well. But for whatever reasons, most of the grossing is done by first year and second year residents, and there are chances that they have missed this gross examination finding.
Yeah, so the very fact that the strap muscle has been included in the section is because of the fact that intraoperatively we felt that there is problem involvement of these structures by the tumor. So that is why that structure was removed, and most of the times we note it down in our intraoperative notes. And strap muscle is the most common structures involved. So other than that, sometimes it involves the lectin glands, the trachea, all these. So most of the time we don't dissect that. What we do is the shape of it. So that again is noted down in the intraoperative notes. So yes, I agree with you that the extrathyroid extension, the extrathyroid extension is when we see disease infiltrating or adhering to the adjacent structures, the visual structures or the vascular structures that are there. That is when we call it as a gross extrathyroid extension, which is most often seen intraoperative. And also preoperatively sometimes you can predict that because in the imaging you can see most of the gross extrathyroid extension that would be there.
Yeah, I agree entirely with Shiva. The gross extension means gross, and that will come out. That will be seen intraoperatively, and it will be noted intraoperatively. A few wisps of the strap muscle sometimes come out with a total thyroidectomy, and I guess if you do see some microscopic disease that has gone into that, that would not really constitute gross involvement of the strap muscles. It's the strap muscles normally don't come out with a total thyroidectomy.
Yeah.
So if they have come out, then that means that there is something. It's either inflammation or it is invasion of the tumor. That's my take on it anyway.
Thank you very much. Any questions? I saw there was some question from student side.
Yes.
What is it?
They asked about the last slide of the same case.
What was the last slide? Actually, I looked at it, but it was
This is
Nikki,
the
right?
last slide, if I'm not wrong.
This is the last slide, yeah. But then we just talked about high-grade features, which we should look for, right? So I think that is pretty much clear. Can we go for the last case?
Ma'am, I have a question. In
Yeah.
all the cases you have discussed, there is no mention of any frozen. So
Frozen, we can talk later on. We didn't input any case with frozen. Indications for frozen for in thyroid is another topic. We can have it on the separate chat. We can finish the last case. I think it's 9 o'clock maybe. Then we can take the questions. Any questions on this current case?
no, ma'am.
So just to say that frozen usually for lymph nodes they do ask for the frozen. Even if they ask any frozen on capsulated neoplasm, many times if we don't see any capsular invasion, we cannot give a diagnosis on frozen section for primary diagnosis on frozen section. Yes, but lymph nodes very commonly they ask for things for frozen section. Primary diagnosis sometimes we can give, sometimes we cannot. Last case is 52 years old female, previously operated case. She was on regular follow-up, and there was a nodule detected. There were nodules detected in thyroid. On FNSA, it was Bethesda category 5. Total thyroidectomy was performed. This is a nodule. Now, who wants to take this case? Who has not talked so far? Kajal. I didn't hear from you. Are you there, Kajal? Kajal, who else is there? Who wants to take this case? Kajal, Manasi, Bhavesh, any of the Apurvas?
Nikki, what about Nikki?
Nikki, where is Nikki? Nikki, want to discuss?
Yes, ma'am.
And there is echo. Okay, what do you see?
Ma'am, high cellularity, ma'am. It's malignant thyroid.
One second. Going for high cellularity, just tell me as what do you see is? It's circumscribed nodular region, isn't it? Okay.
Yes, ma'am. Well circumscribed.
Do you see any capsule?
Ma'am, capsular. No, ma'am. Encapsulated.
It is compressing the thyroid gland. Fine. There is some fibrous capsule, not everywhere, but some of the areas.
Ma'am,
Okay,
some
fine.
places.
Okay,
Ma'am,
tell me
we
what
can
is
see
it?
few nests and ma'am, nesting is seen in this slide.
So here the capsule is absent. Okay.
Yes, ma'am.
Okay, now tell me the tumors about the tumor cells.
Ma'am, solid nests of cells are seen.
Classical. Tell me.
Ma'am, cell
Describe the
balance.
cells. How they are arranged.
Clear
How they
cell
are-
is seen.
Clear
Clear
cells. How they
change.
are arranged.
Clear cytoplasm.
Yes. So what is the differential diagnosis anywhere you see tumor with clear cytoplasm? First thing comes to your mind.
Ma'am, RCC.
And could be a metastatic carcinoma from other organs having clear cell.
Yes, ma'am.
That's
Renal or
quite
adrenal.
possible. That's quite possible. So again, look at this history.
Yes, ma'am.
It is on regular follow-ups. Already operated. We don't know for what. I mean, I know that, but I can tell you.
And parathyroid. Ma'am, cell balance pattern, ma'am. Paraganglioma types.
So paraganglioma type, I do agree with you, but there are clear cells. So clear cells, all those neoplasms having clear cells, they can metastasize, right? That is possible. So what we would do you think it is primary thyroid by any chance? Anyone thinks this could be primary thyroid?
Yes, ma'am. There is secondary changes of thyroid cell tumor. They converting to cytoplasm converting clearing can be seen.
But are you going to call it directly thyroid? Do you see any?
Clear cell.
Yeah, go ahead, Swapnil.
Yeah, other cells are eosinophilic, right?
Yeah.
Yes.
So this is more of a clear cell pattern, and as you said, the prominent thing is the nesting pattern. So in this morphology, paraganglioma, clear cell carcinoma, kidney, and other related tumors obviously come into differential. So if at all this is a primary thyroid tumor, there is no classical thyroid tumor which can look like this. Technically not. Essentially, there's some other tumor, a paraganglioma or some other tumor which is coming here. So in this scenario, what are you going to do? You have a tumor which otherwise does not look like primary thyroid tumor. What are you going to do? What IHC markers do you want to try, or what do you want to do?
So lineage specific markers we can use primary in origin. So we can go for TTF1 or thyroglobulin PAX8. If it is negative, definitely it is not primary and it is a secondary.
I say it is
Tell you that this
positive.
is positive, then what is, and what TTF1 and thyroglobulin negative?
The PAX8 is
Asami,
positive.
can we just
Yeah.
Asami, can you let them look at this? Let them describe what they are
Yeah.
seeing. Just describe what you're seeing. Okay, particularly the high power. Nobody's describing the high power of these cells. You can go to the next one, Asami, because somebody said parathyroid. Okay,
Yeah.
do you think that this is parathyroid? You can get water clear cells in a parathyroid gland, but do you think that this is parathyroid? And if it is parathyroid, why? And if it is not parathyroid, why? Because that is a possibility that you have got an intrathyroidal parathyroid, which can look like this. So what is it that you notice about this thing? Because everybody is running off to IHC, but look at this. Can this be parathyroid? And if it is not, then we have to think of things that have come from somewhere else. Come on, who was it? Nikki, right?
Yes, ma'am.
Yeah, come on, Nikki. Describe these cells.
Ma'am, round two oval cells having abundant clear
Round to
cytoplasm.
oval cells. You think these cells are round to oval? You know what is a cell, right, Nikki? Yeah. You think that the boundaries of the cytoplasm are round to oval? Well, what are you describing? You're describing nuclei and you are calling them cells. Yes or no, Nikki?
Round to oval nuclei, yes, ma'am.
Yeah, so but please describe the cell. So describe the cell. You describe nucleus first. Come on.
Polygonal cells.
They're very large. They're large,
Yes, ma'am.
polygonal. Yes. They have got abundant clear cytoplasm. Yes. All right. Now that's what you notice. You also notice what are the nuclei like? Now you come to your round to oval. Okay.
Yes,
What's the character of the nuclei, Nikki? What's the character of the nuclei? Just round to oval. That's all. Come on. What's the character of the nuclei? What else do you describe in the nucleus? Suha, you want to help Nikki?
We have to see whether there is any.
I don't know what you have to see. See and tell me what you are seeing. Hey, everybody start down.
Chromatin.
Aha. So come on.
Yeah, so
What is the nucleus like?
And it is condensed chromatin like lymphocyte like nucleus.
Lymphocyte like. Yeah.
Is it so small?
There, look, Dr. Asawari is showing you. You think they're small and dark like lymphocyte nuclei? Or can you see nucleoli in some of these?
Yes.
Oh, you can see nucleoli. Yeah, you can see them. Some of them are vesicular, all of them are condensed. So, do you think that this is parathyroid? Have you ever seen parathyroid nuclei? Anybody seen a parathyroid gland? Nikki, you've seen? And the answer is this cannot be parathyroid. You have, yes, some of them are small, but they're not like parathyroid nuclei. Look at this. There are nucleoli in several of these nuclei. So now you have to think of something else, no? Very good. So Nikki, what's your diagnosis now? And you had a history, a beautiful history.
It's typical. The moment you see
I'm sorry.
Paraganglioma.
Sorry, paraganglioma. Paraganglioma. Clear cell paraganglioma. You heard such a thing, Nikki?
No.
No, ma'am. So clear cell carcinoma. Very good. So which are the places where you get clear cell carcinoma?
So the degree of that, clear cell carcinoma.
There are such lovely nuclei. There are even holes in the nuclei in some of these.
Come
Right in
on.
the top left-hand corner.
Somebody said it earlier. Initially,
Renal,
I
ma'am.
I think somebody they just stopped thinking about it. I don't know why. What is it?
Renal, ma'am.
Renal. Very good.
Go ahead.
Renal.
So what it could be from renal? What it could be if it is renal mass?
Clear cell RCC.
Metastasis?
Metastasis from clear cell RCC.
Is that clear? So actually, the morphology is very diagnostic. If at all you're going to do, if you don't have any history, then you may want to do IC to make sure that what is the source of the tumor. Now, in this case, this was a known case of renal cell carcinoma known to us, and this was a clear case of metastatic renal cell carcinoma. So, why we keep this case? Just it's a spot. Renal cell carcinoma metastasis can be seen anywhere in any organ. And when you say this clear cell tumor with typical morphology, first thing you have to think about metastasis from tumors with clear cell morphology. Renal cell carcinoma tops on the list. Okay. So now,
Yes.
any questions? No questions? No comments?
One of them said it as chromophobe RCC, ma'am.
Somebody want to take it? Just looking around.
So the tumor obviously had a lot of plant-like morphology, okay, and that would be clearing in a chromophobe RCC is possible. So this can be a chromophobe renal cell carcinoma, but that is obviously easy to sort out on IC through CK and other things, and that can be sorted whether this is a clear cell RCC or this is a clear cell clearing in a chromophobe RCC. But whatever said and done, the case was put there to tell you that you should keep your eyes open and not put everything into thyroid tumors, primary thyroid tumors. Even the diagnosis like anaplastic thyroid carcinoma essentially is the diagnosis of exclusion many times. Okay, when you have ruled out a lot of other things and then you are calling it anaplastic thyroid carcinoma. So this is just to keep that this is also a part of the spectrum. You do get such tumors. Maybe it is not obviously a common thing to happen, but you should keep your eyes open for what is classical, especially because this was actually on FNAC characterized as suspicious for malignancy without further categorization. We are not on FNAC. This was not called as a thyroid tumor as such, and because the main renal tumor was very long back, the surgery did happen to this patient for a definite diagnosis. Okay, so this patient underwent lobectomy for a definite diagnosis.
So I think that was the last case. Now, any comments again from our chairpersons? Madam,
So,
thank you very much.
Thank
Dr.
you. Yes, thank you so much. Especially with the last case, whatever you are saying, that with the architecture and the morphology, it is very easy to diagnose. Of course, we have given the IHC also here along with it. And diagnosis by exclusion also, that thing also we have to consider. Thank you very much, both Asawari and Dr. Rane, for your very nice elaborate discussion on the slide seminar. And as well as I thank Dr. Guzal and Dr. Kontita Madam also for giving me the chance to share decision.
Thank you very much, Dr. Manjula, for your comments. I would like to thank Dr. Shiva also for his useful comments. And of course, Borges Madam is always there to clarify many of our queries and to make us to think about how to approach the case. I always like to hear from Madam her take on diagnosis and approach to the diagnosis for the cases, especially thyroid. Thank you very much, Madam. Thank you, Dr. Shiva. Thank you, Manjula, Dr. Sumit, and Center of Oncopathology staff. Thank you, the moderators. Thanks, Swapnil, for giving. And thank you all students for your for these interactive sessions. I hope you learned from in this series all the important features for diagnosis of thyroid malignant tumors and even benign lesions. Still, if you have any questions, anytime you can contact us. Thank you very much.
Thank you, Asawari.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
And I think we have to thank Kanyapan, who has been standing in for Ruchi. He's always the backbone of this thing. And thank you to the moderators who have done a very good job. Right. So.
Thank you, ma'am.
Any final comments, Anita, you or any of the speakers, Swapnil? Anything final you want to say to the students?
No, I just think that the students have been very good. They've been volunteering to
discuss the cases. Yeah.
Yes, to discuss the cases, which is really very good. And of course, most of them are third-year students, I think, and there are just one or two second-year students. But it's a very good effort. And like I always say, that all of you are standing in for the audience through your your answers and the way that you approach the whole thing. The others learn. So I think that the whole audience has to be grateful to the students as well, because their problems, the audience, their issues, their problems are all solved through the interaction with the students. So I think that that's really great. Thank you.
Thank you, ma'am.
Thank you.
Thank you, sir. Yeah, and good luck to our students, sir.
Thank you, Asa. So we'll keep the replay link for 2 more days. I think the Sunday, and we meet next Tuesday. Next week we have one talk and a seminar. So coming Tuesday, we have Anita doing a surgical path seminar on 2nd January.
Yeah, actually, it's a continuation of my salivary gland seminar, and the slides are already there. Okay, so on the Telegram, but I've asked Ashish Shah to put it up again. Okay.
Okay. And 4th
so
January,
that's on the 2nd, yeah.
And on 4th January, Dr. Shubhra Kane, she's going to speak on pathology of sinonasal tracts and larynx. So
okay.
Thank you, everybody.
Okay.
And
Thank you.
Nice
good night, everyone.
Thank you, Asa. Dr.
And
Manjula.
Happy New Year to everyone. Happy New Year.
Happy New Year.
Happy New Year.
Oh yes, Happy New Year.
New Year, ma'am.
Yeah,
Thank you.
in 2024 now.
Yes.
Almost
Bye.
there.
Thank you very much, Bindu.
Bye-bye.
You've been great.
Thank you.
Thank you,
Thank you.
sir.
Thank you very
Thank you.
much.
Bye-bye.
Bye.